Very good evening to everyone. Welcome to the fourth session of Masterclasses of Critical Care Medicine from Yashoda Hospitals and ICCM Hyderabad. Today's case for discussion is acute liver failure. For this case to present, we have our DNB students from Yashoda Somajiguda, Dr. Anand Ram and Dr. Kondal Reddy. They will be presenting the case. And examiners for today are Dr. Sunil Karanth, sir. He is HOD, Department of Critical Care Medicine from Manipal Hospitals, Bangalore. And another senior consultant, Dr. Pavan Kumar Reddy, he is HOD of the Department of the Critical Care Medicine from Hyderabad, Care Hospitals. Dr. Anand, you can present the case.
Sir, good evening, sir. Good evening, Sunil sir. Good evening, Pavan sir. I'm from Yashoda Somajiguda, sir. And today I'm going to present about a case of acute liver failure.
Doctor, be a little louder.
So, a 36-year-old male with no known comorbidities presented with chief complaints of abdominal discomfort since 10 days, generalized weakness since 10 days, fever for 3 to 4 days, 10 days back, and ileous discoloration of sclera for 7 days, and decreased food intake since last 7 days, and decreased urine output since 2 days. So, coming to present illness, symptoms were insidious in onset and gradually progressive over a duration of 10 days. So fever subsided with medication. He has taken paracetamol, but the dose is not known. And no history of vomitings, loose stools, and no history of hematemesis and melena. And history of outside food consumption on a regular basis is present. And past illness, no previous history of jaundice from childhood. And no other known comorbidities like diabetes, hypertensive, CAD, old PTB, and bronchial asthma. And no similar complaints in the family, and personal history is a normal bowel and bladder habits, and takes mixed diet, and known alcoholic, and increased alcohol consumption since the last 3 months. And general examination, moderately built and
Dr. Raman, we'll just hold for a minute. What are the differentials you will think of from the history? You can go back to the first slide for the benefit of the audience, or you can just summarize in 2 lines. 36-year-old, yeah.
So 36-year-old male presented with the chief complaints of abdominal discomfort, and ileous discoloration of sclera, and generalized weakness, and history of fever is present, sir. And he is having a history of outside food intake on regular basis, and history of alcohol intake is there, and increased alcohol consumption since last 3 months is there.
Yeah. Can you give some differentials for the current symptom complex or the history that you know?
Based on
gentleman, 36-year-old with no comorbidities, alcohol intake history is there, recent increase, and sort of vaguish complaints, including fever. Yeah. So, and jaundice. So, what are the possible differentials?
So, history of fever is there, sir. So, it could be a viral hepatitis, one possibility. And outside food consumption history is also there. That also goes in favor of viral hepatitis. And increased alcohol consumption is there. So it could be alcoholic hepatitis, one possibility. And he has taken medication for history of fever, sir. Some before coming to hospital, some 7 days back, like that. For 2 to 3 days, he has taken paracetamol tablets, dose not known. So it could be paracetamol-induced liver injury also. And and other rare possibilities are
Anything else? Yeah, I mean, because the topic is acute liver failure, you're focusing around hepatitis.
And
But
tropical fevers,
yeah, good. Tropical fevers such as?
like a scrub, leptospirosis,
Correct.
typhus,
Any
leptospirosis,
any
and
other
dengue fever
differential?
also.
Any other
And
differential?
Plasmodium falciparum.
Yeah, all that comes under tropical. Any other differentials? So viral hepatitis or hepatitis of any etiology starting from viral to alcoholic to other things, drug induced, perfectly you said. You said tropical. Anything else you would want to consider with this differential diagnosis?
Rarely pancreatitis also may cause, but it can't cause jaundice, sir. But
Why not?
abdominal
Why
discomfort.
not? Is there any illness or any etiology of pancreatitis which can cause jaundice also? In fact, it is a very common type.
Yeah, gallstone, sir.
Yeah. So it could be gallstone pancreatitis, which can produce obstructive kind of jaundice. Anything else? You're good so far. Keep it going. So don't restrict yourself to the topic.
Any intra-abdominal sepsis,
Correct.
like liver abscess also sometimes possibility, sir.
Yes. Any intra-abdominal sepsis? Good.
So
A little more specific.
Sir, any malignancy also.
Good, excellent.
But there is no.
Could be. Yes, could be.
Yes, sir, could be.
Anything else? Almost done. I mean, I
Yes.
just have one. When you said liver-related infection or whatever, you told about abscess. Is it so common in abscess, this presentation? Vague abdominal discomfort?
No, sir. Mostly they will have fever and abdominal pain.
So what is more specific related to the gallstone pancreatitis?
pain, abdominal pain will be severe, sir, and pancreatitis, epigastric, and pain over the back also most common.
The chat box differentials are firing out left, right, and center.
Yes.
So what are the classical features?
Obstructive jaundice, any etiology, isn't it? Could be cholangitis, could be gallstones, could be malignancy, whatever. Okay. Dr. Pavan, you have anything to add?
Yeah, so differential diagnosis. You have gone to malaria, you have said scrub, you have said lepto. Any other tropical infection that you think of?
Viral infections, herpes simplex, varicella zoster can also cause, sir. But
any other tropical fever?
So dengue fever, we can malaria, dengue, scrub typhus, and leptospirosis.
Yes.
So we can. There possibilities.
Yes.
And for that matter, could be any other sepsis also. Lower down the list. This kind of vague presentation can be possible. But yeah, I think more specifically focused on abdomen as the primary source is rightly as you said. Yeah. Okay, I am okay to go ahead, Dr. Pavan.
Yes, we can go.
Yeah. So just for the benefit of the students, see, many times you may know what the case is, but don't be, the idea in the exam is not to stick to the case. Obviously, we know that you would know the case. So we want to see how well you will arrive at your differentials in what order of priority. Now the priority could be your order may be different from what I may be thinking, but if you can justify why you are giving that order, we'll be perfectly okay to accept it. Okay. Yeah.
so general examination, no pallor, no cyanosis, no clubbing, no generalized lymphadenopathy, and no pedal edema, and icterus is present, and vitals are stable, BP 110/70, heart rate 97, rhythm is regular, so no radioradial or radiofemoral delay, all peripheral pulses are present, and saturation 96% on room air, temperature normal, and GR base is 86 milligrams per deciliter. And systemic examination, coming to G8 examination, so abdomen on inspection is distended, umbilicus is inverted, no localized swellings or any discoloration or any visible pulsations, and no visible peristalsis, no visible scars or sinuses, and no dilated superficial veins. And the palpation temperature is normal, no rigidity or no guarding of abdomen. So tenderness present in right hypochondriac region. So liver span is approximately 4 centimeters from right costal margin in mid-axillary line. And percussion, tympanic note on percussion, and no fluid thrill or no shifting dullness. In auscultation, normal bowel sounds heard. So other system examination, CVS, S1, S2 head, and epical impulse, fourth intercourse please, no murmur, and bilateral ARNT present, and neurological higher mental functions were intact, and disorientation is present, and no focal neurological deficits.
Okay. So we'll stop there. Go back to the prior slide. So what are the clinical signs that you have enlisted which are positive?
Clinical signs, icterus is present, sir, and GRBS is slightly low, 86, and abdomen is distended, and tenderness is present, right hypochondriac region, and vitals wise is stable.
Neurological.
Anything else?
Neurological, disorientation to time is present, but higher mental functions are intact.
If I would ask you, do you want to look for anything more specifically which may not have been mentioned? I don't know whether I missed it, but which may not have been mentioned in this particular examination sequence that you have explained. Icterus, stable vitals, tenderness.
Okay.
So
In history, we can ask the occupational history and
All right, you want to start from history? Good, all right. So occupational history, fine.
any sexual history also we can ask.
Okay.
And if he is in a chronic alcoholic, so we have to see the any periodic enlargement, loss of 1/3 of hair loss, gynecomastia, testicular atrophy, and muscle wasting, chronic.
What are you looking for? You're right. What are you looking for? Just for the benefit of the audience.
To
Why are you
liver
looking-
failures. In chronic liver disease,
Chronic
the
liver failure,
signs of
yes.
liver failure.
Good, good. Yes. Then
So what are the different signs of a chronic liver failure? Clinical signs that you look at. Like you said, there are a few. Gynecomastia.
Dr. Pavan is very clear. Signs.
Signs.
So in case of finded a Cullen sign and a return sign also we can expect.
Chronic liver failure. Chronic liver failure.
In
Yeah, let us say more pertaining to ICU. Obviously, Cullen sign and all, where you can't do like puddle sign and all is very hard to make. No, let us stick to a critical care patient who presents with these. What are the signs? That's what Dr. Pavan is asking.
yes.
Head to toe, you can go. Chronic liver disease signs.
Palmar erythemas, spider neve, palmar erythemas also we can see.
Okay.
And anyway, jaundice we told Elias discoloration.
Mhm.
In case of cholecystitis, they will have more pain in sitting position, and if you ask the patient to deep inspire like Murphy's, and also we can expect in case of cholecystitis.
Any ulcers over the lips and tongue, we can see, to rule out any viral infections like herpes and all, we can.
So don't mix up now. Dr. Pavan asked you for chronic liver disease signs.
Yes. Palmar erythema, abdominal wall vein engorgement, abdominal distension, spider neve, palmar angiomatrosis, flaps, liver flap,
Flaps, yeah.
hysterexis.
Anything on the abdomen other than that? Other than
Everted umbilicus.
Illness, fluid thrill and shifting illness. If ascites is present, we can LC.
Okay. Coming to this case particularly, now that you have some disorientation to time, what do you think it is? Why is it disoriented?
Sir, if is it encephalopathy, we can disorient it to time. So mostly is in grade 2 encephalopathy, we can suspect.
Okay.
Because
so what are the other causes of encephalopathy in this condition? You might think grade 2 you are saying, or hepatic encephalopathy you are saying. But what are the other types of encephalopathy that this patient can also have?
So hepatic encephalopathy, one possibility, sir. Other, it could be septic encephalopathy, but so high grade fever is not present. So rare. And, metabolic encephalopathy. So in electrolyte disturbances superimposed on this liver failure can cause encephalopathy. Any other toxin induced or rare, but no history of consumption of any other toxins like that. So other causes are metabolic, septic.
What are the different metabolic causes that we can think of for the patient's disorientation to time?
So liver.
so they will have uremic encephalopathy, they will have hyponatremia. Chance of hyponatremia is more in liver disease patient. So hyponatremia, hypokalemia, and uremic also, they will have acute kidney injury. So they will have uremic encephalopathy.
You should never forget hypoglycemia. Okay. So any patient who comes, first thing is hypoglycemia, which is easily correctable.
Most important thing you missed actually. Yeah. So see, many times in chronic liver disease, hyponatremia is of slow onset. So we really don't, as Dr. Pavan said, not really clinically significant they come up to. No? So hyperammonemia and hypoglycemia is very important, and septic, of course, as you said. Okay, we'll proceed.
Yeah, the differential diagnosis now at this phase. So you have a guy who's altered sensorium, who's got fever, who's got icterus, who's got tender hepatomegaly probably, because you could measure the liver port and intercostal space in the right side, right? So what else could it be? The differentials at this point, again.
Yes, sir, is outside food intake and fever history, we can suspect viral hepatitis, sir. And second one is tropical fever, we can suspect. And
1 minute. Now you have the whole picture in front of you, no? So how will you write the diagnosis? Usually in medicine or any time when you write a diagnosis, how do you write it?
yes,
You finish your case sheet with the end of this thing. So what are the differentials you're going? How are you going to present the diagnosis?
yes, a 36-year-old male gentleman is...
No. Don't summarize again.
Yes.
I think Dr. Pavan has already summarized it very well for us. Just based on this, what are the differentials? Viral hepatitis, I am not denying it, but how will you write the full diagnosis?
Acute liver failure with encephalopathy, with the jaundice.
How do you define acute liver failure?
Exactly.
What is the definition?
Acute liver injury, which is characterized by coagulopathy and encephalopathy without any underlying chronic liver disease or cirrhosis. Time duration is less than 26 weeks from jaundice to encephalopathy.
So does it fit this?
Yes, sir.
Without any coagulopathy? Do you have the coagulation parameters at this point?
Yes, sir. We don't know the coagulation parameters, but encephalopathy is there and jaundice is there. So history is more than 7 to 10 days. So mostly acute liver failure it will fit into.
Okay.
So yeah, you have to say my differentials are like, that kind of a thing. So it's possibility of course, not possibility. Here is a 36-year-old male who is encephalopathic, possibly of hepatic origin. Likelihood of acute versus acute decompensated versus so that way you have to sort of this thing, because if you only say viral hepatitis, it doesn't mean anything. Same thing. We don't have any lab yet to say that. Okay. So yeah, okay. For the liver failure, you are saying one is viral hepatitis. Anything else? Any other etiology you want to think of?
Drug-induced hepatitis, sir.
Okay.
And cholecystitis, pancreatitis also we can expect.
But it doesn't change much, isn't it, after that, after the history? Okay, go on. Go to the next slide.
Provisional diagnosis, viral hepatitis and other septic causes like tropical, bacterial or liver abscess, and drug-induced liver failure, very paracetamol-induced, alcoholic hepatitis, and acute cholecystitis, and acute pancreatitis.
So let's go back. How do you go forward from here? This patient has come to you in the emergency. They've asked you to come and see this patient. He is there in front of you. What would you like to do?
Yes, sir. Yeah, I want to rule out the each and every cause by asking history and by communication with the patient. So I will ask the drug history, how much paracetamol he took and how many days and what is the dose of paracetamol he took in course of illness. And one more thing, outside food intake, any traveling history we will ask, and dosage of alcohol also I will ask how much he is taking and how many days he is taking the alcohol. So the quantity and everything will ask.
Okay. So you have got enough history now. How will you approach next? What will be your action?
Sir, I want to rule out everything. So in these causes, so I will order the investigations after my general examination and diagnosis. So I want to rule out the infection. So I will order the complete blood picture. So I will check the TLC and I will any previous history of any bleed. So I will check the hemoglobin levels and TLC and platelets counts also. So mostly liver failure patients, mostly they will present a coagulopathy. So I will order the PT and INR and APTT. So liver function test and renal function test and ammonia levels. Chest X-ray and chest X-ray also will have.
Anything else?
And ultrasound abdomen. So one is to know the SITs are present, now the gallbladder status, liver morphology, and any retroped pancreas morphology also I will check. Hepatomegaly or splenomegaly, any intra-abdominal, any SITs. And tropical fever also I have to send, sir, like dengue and second week. So dengue, IgM, scrub typhus, lepto, and plasmodium also. And we are suspecting the bacterial infection. So surveillance culture also we can send. I will send.
Well, first important thing should be for you to understand the diagnosis, to confirm your diagnosis, which is of the most important of those tests that you would do.
LFT is most important.
You would want to do first LFTs as a common LFTs and a routine CVP is the initial test. There is no point in running to panel because you think the diagnosis is something that is given to you. So you are running into all kinds of serologies and everything. But first of all, baseline, look at the complete blood picture, complete hemogram, then look at the ultrasound. Okay. If you think your platelets are 20,000, right, and the patient's TLC is 4,000, you would probably look at dengue rather than running behind everything. Isn't it? Okay. The first things first, what you need to look at is what are the different things that you think? Don't run behind investigations all the time. First is what is most essential to come to the diagnosis first. And if the patient is unstable, how would you stabilize him? At this point of time, the BP, everything is fine, but he has got a decreased urine output. So what would you do?
One
So
is
he's
the
anorexic, he's lethargic, right? At this point of time when he came, he's got fever for 1 week, he's lethargic, he is anorexic, then he's got decreased urine output for the past 2 weeks. So how do you approach this point?
So based on history, mostly pre-renal could be cause, sir. So fluid challenge we can give, and we can see if he is responding.
Would you check his glucose? You're all forgetting again, sending off all labs, but not checking glucose, not checking simple things. Check the CVP, check the glucose, right? So this patient has a glucose of 40, less than 40. What will you do?
Yes, sir. He is an alcoholic patient, so mostly he is in grade 1 hepatic encephalopathy. So we will give the thiamine and most. So then we will give the dextrose to prevent the encephalopathy. So he is a chronic alcoholic. So they will have mostly deficiency of vitamin B1. So chance of worsening of encephalopathy is more in case of these alcoholic patients. So if he is less, so we'll supplement with thiamine, then we'll give the dextrose.
How much thiamine will you give?
300 mg, stat. 300 mg stat, followed by 25% dextrose, 100 ml bolus.
What will happen if I give directly dextrose, not thiamine?
Sir, mostly these thiamine deficiencies, so they'll mostly they will go to the anaerobic metabolism. So chance of encephalopathy, vernix encephalopathy is more. So thiamine is involved in glycolysis cycle. So
glucose cannot be cannot go into Krebs cycle, sir. It is diverted into anaerobic metabolism. It cannot be utilized for ATP production if you don't give thiamine. It cannot enter the Krebs cycle.
Dr. Karanth? So you've done a CVP, you have done an ultrasound. Then what else?
If you are in a very good hospital, which obviously you are, what are the other point of care tests you would want as well? So as Dr. Pavan said, CBC you've done an what you call a GRBS. Anything else?
liver function test.
Yeah, that will take time.
Anything else? Point
of care, which may have a huge bearing on the immediate management also.
Urine for ketones, we can check.
Okay, maybe.
ABG, sir, ABG.
Blood gas, no? ABG, VBG, anything. Blood gas is important. What will it?
Why? What will it be?
Yeah,
what are they expecting?
ABG.
They will have
decreased lactate clearance in liver failure patients. So hyperlactatemia can be there. And, so acidosis can be there. Associated with renal dysfunction is there. Acidosis can be seen in ABG.
Okay. So what is the cause for lactic acidosis in such a patient? One you said is liver clearance is there, not there. But first lactate to be produced for the liver to clear, isn't it? So if the lactate is high, what are the different causes of lactic acidosis in this case?
yes, sir. One is hypoperfusion state, next to sepsis, any intra-abdominal, any mesenteric ischemia, and anything like sugars decay also we can just sometimes.
I think Dr. Pavan is referring to this context, isn't it, Dr. Pavan?
Yes. In this patient, if let's say you are done an ABG,
do you expect ischemic bowel here?
let's say the lactate is 4. Yeah, what would you think the causes are?
Perfusion, hypovolemia, renal dysfunction, sepsis induced hyperlactatemia.
Hypovolemia, maybe sepsis, and anything else. First on the list would be what?
Liver.
What is the diagnosis?
Liver dysfunction.
That
Liver
itself cause.
Liver dysfunction.
Okay. Next, what are the other investigations you would want to do? We'll proceed now, Dr. Pavan.
Yeah, sure.
Yeah. So you have a set of provisional differentials. You said you will do a CBC. Okay. Just tell how you manage the patient in the emergency. You have been called to the ER. This picture is there. What all investigations and what is going to be your line of management?
So if lactate is 4 and you have to start, so immediately secure IV access and airway breathing circulation should be stabilized, sir. First. So if
so in this patient, you refer to this patient, airway you are assessed. Do you need to do anything? So go in that sequence. I'll assess the airway breathing circulation. Airway, anything you need to do?
No, sir. Breathing pattern and saturation were normal. So airway is normal. So breathing pattern also normal. Airway breathing normal. Circulation BP was stable.
So you will secure an IV access. Okay. Then you will send off investigations. You told me CBC. You told us blood gas, sugar, of course. What else would you want to do?
Liver function test and ammonia will send, sir. And viral markers like HBsAg, HIV and HCV. And
see, I think you have to understand that, Dr. Kondal. Yes, they're all fine for the example, but when you see in a clinical setup, you first go for basic RFT and LFT. If they are abnormal, then you look into the subsequent test. Okay.
Nobody told renal function actually.
Yeah. So you send renal function, liver function test. And because see, your prime issue is liver issue. You want to see liver dysfunction. If that is there confirmed, then you go for subsequent test. Okay. You should not never go in a battery of tests sending everything in the world. Okay.
So when you answer in the exam, as Dr. Pavan put it, it is not, we are not testing your theory knowledge. We are looking at your application of your theory knowledge. Okay. That's why we have a clinical exam. Otherwise, we would have had a theory exam alone, isn't it? So airway breathing circulation, I will stabilize. I'll send off basic investigations. CBC, why do you send? Bun creat, because I suspect there could be a renal dysfunction, LFT, and blood gas. Based on these tests, I will plan for further tests. That's how you need to answer the question. Because if you keep on rattling out everything under the sun, then you are not a ICU trainee, isn't it? We want you to be specific. You have to come out as a ICU trained person. Okay.
Okay, let's go to the labs. There's a lot of big battery of tests. Don't get influenced by what is there in the slide. Okay?
I think that is the problem.
That is the problem. Because you have to think bigger, right? So, you see a viral marker there, you send off after hemogram, you don't send viral marker directly, right? More importantly, we look for doing the regular ultrasound abdomen, and yes, tropical fever panel, depending on again on the lab. If the lab suggests some sort of a clear cut picture, look at them and then go about it. Okay.
So what are the things that you would expect, or the abnormalities you would expect if you are talking about a hepatitis? I'm not talking about the etiology. Just explain to me what are the possible or what are the findings, abnormal findings in the liver function test you would expect for a hepatitis.
Sir, in hepatitis, there will be elevation in the AST and ALT levels. And
By how much?
In
How much do you call it as hepatitis? How much do you call it as transaminitis?
more 50 to 100 times upper limit of the normal.
50 to 100 is a lot, man.
1 to 1.5 times is transaminitis, sir.
Yes.
It is elevated in hundreds. It is could be alcohol induced.
More than 3 times. Some authors say 5 times, some authors say 3 times. If it is more than 3 to 5 times the thing, we call it as hepatitis. Otherwise, it is only called as transaminitis. Okay. So that is very important, because when you write the diagnosis, you cannot sort of waver. So most often it is 3 to 5 times. Generally 5 times is accepted, but some of them even say 3 times, but keep it as 5 times. Okay.
So
Okay.
what do you expect in this patient, for example? What do you see in hepatitis? Let's say, like Sir said, you have seen some sort of a SGOT, SGPT, or DDA. What else are you expecting in the LFT?
If it is alcohol-induced hepatitis, mostly SGOT, HCPT raised in hundreds, sir. If it is viral etiology, it will be in the thousands, around more than thousands, like that. And if it is ischemic hepatitis, they are raised even more, sir. Some 3,000 to 5,000.
Okay, let's go to next slide. Okay. What are the abnormalities?
So abnormal INR is raised, PT is raised, and PT is 24.4 and INR is 1.8. Creatinine is abnormal, 2.5. And SGOT, SGPT is raised in around 2000s. And total bilirubin is also raised 39. And urine output is borderline, 32 means 40 ml per hour. Nicterus is present, and patient is a little bit confused also.
So what is the diagnosis now?
So SGPT were raised in thousands. So and SGPT is raised more than SGOT, sir. So it could be mostly viral hepatitis. In alcohol-induced hepatitis, so mostly SGOT will be high than SGPT. In this case, SGPT is raised more than SGOT, and one possibility is viral hepatitis. And bilirubin is also raised.
Which are the conditions where the SGOT is higher than SGPT? I mean, which may suggest etiological conditions where you find that SGOT is more than SGPT.
SGOT is more than in PT in alcohol-induced hepatitis. PT is more than OT in viral hepatitis.
Okay. Alcohol, one, then?
Tropicals.
Tropical, more specifically dengue, no? Then
Yes.
one more. Ischemic as well, okay. These are places where you might find the OT is higher than PT. Not necessarily, but can be. Okay, go on.
So what is the diagnosis now? You got your INR. Patient is confused.
Yes, sir. Acute liver failure.
Only acute liver failure?
Acute liver failure because of viral hepatitis, we can think so one thing. And
with encephalopathy, with AKI, and with hyperbilirubinemia.
No, hyperbilirubinemia is part of liver function. Don't bother about that. Yeah. Can you define what is acute liver failure?
sir, acute liver injury, which is characterized by encephalopathy and coagulopathy, INR is more than 1.5. The onset of jaundice to encephalopathy, the duration is less than 26 weeks without underlying cirrhosis or any liver disease.
Correct.
Can you subclassify them?
Classify, yeah.
Yes, sir. It is classified as hyperacute, acute, and subacute, sir. Hyperacute is up to 7 days, and acute is 8 to 21 days, and subacute is 21 to 12 weeks, sir. More than 12, it is late onset. We used to call.
Yeah, so there are two classifications.
Yes, sir. O-grade classification
Yeah.
and Japanese classification also will have, and one more thing, Bernoulli classification.
Yeah, so usually the O-grade and Japanese are commonly used. So be aware of the differences. I think one should suffice, but okay. What is the reason of knowing this classification?
Sir, one by knowing the hyperacute or acute, sometimes we will know the cause of the liver failure. Sometimes we can expect the complications which are more in hyperacute and acute, and prognosis is very good in hyperacute. So we can prognosticate the patient by knowing the duration of the symptoms and by the classification also.
Good. So now you know that this patient has acute hepatitis with hepatic encephalopathy and hepatorenal also, no? Creatinine is how much? I forgot.
2.5.
2.5. So there is hepatorenal as well. So what are the differentials or what are the further tests you want to send to look at the etiology? Or first you give me the differentials for hepatitis.
Yes, sir. One drug-induced hepatitis we can and viral hepatitis we can suspect. So after this, we will send the viral markers, and more common hepatitis A and E also common. So we'll send the IgM, and if we suspect a drug-induced hepatitis, we'll send the paracetamol levels also.
1 minute. Go step by step. You said viral hepatitis first cause, drug-induced second cause. Anything else?
Tropical, we'll send the tropical workup,
Okay.
like dengue, scrub, lepto.
What are the common viral hepatitis or hepatotropic viral infections in India?
Herpes and cytomegalovirus. Herpes will
Common.
Hepatitis A and E, sir.
A.
Common. Hepatitis E is more common than hepatitis A in incidence wise. Hepatitis B and hepatitis D, other common viral etiology. And hepatitis C, but it's seen in chronic CLD patient. It doesn't present as acute liver failure, sir. Mostly chronic presentation.
Other viral diseases?
Herpes simplex virus, varicella zoster, cytomegalovirus in immunocompromised patients.
What are the drugs?
Drugs mostly in India, anti-tubercular drugs are most common cause. Now outside India, it is paracetamol is most common cause.
It is the second common cause of in India, according to the INDI this thing study. Indian network is there. No, you know that there is a network, Indian network for drug-induced liver injury, which is the commonest is ATT, all right, about half of the total number of drug-induced. Second common cause is what?
Antibiotics.
No, that's not second common. What is the second common? According to there's a paper, it's a network data which came out in 2018, I think.
Epileptics also.
Yeah, these are there, but second commonest cause, which is very rare in the Western world. CAMSMAN, contemporary and alternative medicine. Okay, this is the second common. 15% according to the network data is actually from in India. I'm talking about 2018. I think that this thing came out. All right. So ATT is the commonest. Second common is this thing, and then of course a whole lot of other things. The rest of them are between 5 to 8%. So about 50% is ATT. About 15 to 20% is this unidentified this thing where there's a very strong history of ingestion of some alternative medicine, and of course there are all the other medications.
Okay, how do you go about now? This patient has become confused. These are the labs. You have sent viral markers. Then what will you do? It will take time for the viral markers to come, right? So what will you do now?
So we will stabilize the patient, sir. And
He is stable, vitals are stable. What is the most stabilization you want to do? Temperature normal, vitals stable. What do you mean by stabilization?
so we can.
You know the probable diagnosis: acute liver failure. He has got AKI, acute kidney injury, right? And he's in encephalopathy. He's got decreased urine output. So what will you do?
Yes, first fluid resuscitation. So if we want to correct the hypovolemia, so we want to correct the hypovolemia to improve the urine output, one, and to anti-encephalopathy measures. Three, and the coagulation parameters.
So if you are suspecting any drug-induced hepatitis, we can give NSTL-16, sir. So
I'm not asking what we can do. I'm asking what will you do? Okay, doctor, do you want to admit him? Do you want to admit him in what? Let's say
Again, specifically, this patient only we are talking about. So if you want to deviate from here, we will ask you, okay, this patient, how do you want to manage from here on?
we have to admit in ICU as sensorium is means he is disoriented to time. Chances of hepatic encephalopathy will be there. Progression of disease and chances of hepatic encephalopathy will be there. So we can't manage in wards. So we have to admit in ICU. We have to see daily. We have to assess sensorium so that any progression of HE is there or not. Daily we have to neurological assessment we have to do. And any further deterioration of any urine output, already it is borderline. Any further
what will be your instructions on the sheet? Let me put it this way. What is your plan? What do you write? What are your instructions to your nurses? Or what will you think and write in the case sheet? What is your plan? There should be a sequential plan, isn't it? What will you do?
So closely monitor sensorium, any deterioration of sensorium, and
organ-specific management and general management, and general management will give the fluids and will maintain the urine output, and organ-specific management.
No. 1 minute. Give the fluid. When you say give the fluid, what it means? Will you tell the nurse? Will you tell the nurse you give fluid and walk away?
Yes. We'll start the crystallites initially 30 ml per kg. We'll give the bolus and will maintain the patient with maintenance fluids like
Doctor, this is I'm asking what will be right in the case sheet. Okay, give me what are you going to write a plan? You're going to write a plan, right? You're not going to say 30 ml per kilo and then you're saying maintenance fluids, right?
Yes.
What are the general measures? Okay,
general what I will fluids and stress ulcer prophylaxis I will write, and encephalopathy measures like I will start the like a oral non-absorbable antibiotic and enema and lactose syrup, like nutrition. And,
no. Doctor, see what Dr. Pavan is very clearly asking is, tell us what will you write on the chart. You can't say non-absorbable antibiotic, fluid. Tell what fluid, how much, what non-absorbable.
So choose whatever you want to choose. We don't care.
What will you normally do in the ward?
Sorry,
in the ICU.
As for close monitoring of sensorium fluids, if there is hyponatremia, we can start NS.
You have that labs here in front of you, sir. Okay, the sodium is 132. Don't go into postulating into theory. You have that clinical picture. The patient is in front of you. What are you going to write in the chart? The sodium is 132, chloride is 96, potassium is 4. Everything variables are there in front of you. The bicarb is 22, the creat is 2.5. You have the labs also now. What are you going to do? What are the instructions that you give to a nurse? What do you do? How do you talk? How do you talk to the family? What do you talk to the patient? How do you assess him further? What are you going to write?
So as the sugar is low, we can start DNS, sir. DNS fluid. Sugar is 85, 86. Hypoglycemia is there. So in liver dysfunction, chances of hypoglycemia will also there. So we can start DNS fluid. So potassium is high, so we can avoid a plasmolate as of now. We can start DNS fluid, and anti-edema measures we can start.
What are the anti-edema measures? Just writing what
Yes.
will write in the case sheet anti-edema measures. I've never seen anybody write anti-edema measures in the case sheet.
No, sir. So head end elevation to 30 degrees and
Encephalopathy measures like calm environment, head and elevation, which is neutral position.
What is calm environment means? Is your ICU calm?
Yeah.
Any
Which is
specific
the calm
thing you will tell?
environment.
What will you tell? What will you do? Calm environment means what?
anti-edema. So 3% NS or mannitol. We can.
You will write 3% or mannitol.
So
What will you write, Baba? What you see a patient? Just I'm asking, what will you just think of this as a patient in front of you? Don't go
Yes, sir.
theory. Strike out theory from your head. See in front of you, there is a patient. What will you do in real practice? That is what is important. Do that. Just do that. Okay. Tell me what you are going to do when you see a patient like this. Simple thing what you are writing. Okay. You write a plan, isn't it? You have to start thinking about a plan. When you see a patient, these are the labs that have come. Okay. Blood cultures won't come today. Right. A viral panel will not come on day one back. They'll take time. Right. Even where dengue may take 1 day, 2 days time for the IgM to come. Leptospira will take time. So what is that? There are no tests are going to come back. You have to, what you have in front of you is what you see routinely. You are write some prescriptions, write a plan. The plan is you're saying you want to put in a calm environment. What does exactly calm environment mean?
Routine monitoring by heart rate, BP, and SpO2, and respiratory rate and sugars monitoring, and then we'll coming the hemodynamic monitoring. So we'll check the BP and we'll give the IV fluids and we'll monitor the output. Then we'll start the antibiotics. If we are suspecting tropical fever, we'll start the antibiotics and encephalopathy measures like
what antibiotics? Tropical fever, malaria is also tropical fever. Scrub is also
acute undifferentiated fever. We can start with the third generation cephalosporins. We can start. We are suspecting the lepto, and we can start the doxy, and then neurological protection also, like same anti-encephalopathy measures, either mannitol or 3% NaCl we can start. But if patient is having AKI, so 3% NaCl is the choice, and target sodium is 145 to 155. And the target semi-solid loose motions, like to prevent the encephalopathy, is more than 2 per day. So we'll start the lactose enema or lactose syrup 30 ml TID or enema we can BD, and we have to monitor the sugars like every 4 to 6 hours.
4th hourly or 6th hour? 6 to 1 6. Right? So
yes.
Whatever you do, you have to be clear cut and precise on that. You cannot write things on the case sheet, isn't it? So think about what is natural process. Don't
So
go
see,
don't jump to theories.
See, when you make a plan, just think of what you would normally do in the ICU. So of course, it's always going to be airway, breathing, circulation. So I'll ask my nurse to monitor the airway, breathing, circulation. Of course, you will get 2 peripheral lines. And if you say IV fluid, you have to justify how much fluid, bolus if you're going to give, maintenance, what, this thing, and go system wise. for CNS, this is what I would advise for monitoring treatment, cardiovascular monitoring treatment. So, that way you will not miss out on anything. Because if you go like a berry picking here, there, everywhere, no, it is you're just plucking in the air. Okay. Go on.
Okay, you have started on IV fluids. Then I could hear you give some 3% NS because you don't want to give mannitol because creatinine is up. So you're giving 3% NS and you are targeting some sodium level, right? So you are telling you will only check sugar, but you are not telling whether you will check sodium again or not. You're just saying I'll maintain this sodium. So will you do it once in a day or twice in a day, once in 3 days? That is one thing. So you have to mention those things on the case sheet, isn't it? You say repeat sodium and sugars 4th hourly or whatever it is, right? So something, whatever you write in the case sheet, that is important, isn't it? So you tell us what you are going to write, how you are going to go ahead, whether you want to repeat an ABG, whether you want to repeat a glucose or a sodium at what frequencies, at what intervals. So basically you're giving out instructions to your nurse. At the same time, you're telling why you want to do it by rationalizing what you are doing. You're just telling me what you are thinking. At the same time, you have to tell me what you are writing in the case sheet also. Okay. So yes, then GCS you are monitoring if the patient is deteriorating or not. Right. What else? You said you will start a 3rd generation cephalosporin. Please give out one 3rd generation cephalosporin. Which shows how much? Yes. Please tell me how much injection. Ceftriaxone.
Ceftriaxone 1 gram IVBD, IV 12th hourly.
Right. Then doxycycline, why and how much? Simple.
Doxycycline,
right?
I want to call that scrub and leptospirosis, tropical scrub and leptospirosis. So the doxy 100 mg IV 12th hourly. Then test ulcer prophylaxis injection PAN 40 mg IV 24th hourly. I will.
Doctor, don't get to the habit of talking trade names. Pantoprazole.
Pantoprazole.
Okay. Go on.
Yes. I will ask the sister to reserve the blood product, like fresh frozen plasma. He is having coagulopathy, but any intervention if we want to do. So I will ask the nurse to reserve the blood products, and I will check the urine output. Hourly urine output I will more than 0.5 to 1 ml per kg per hour. I will maintain.
What is your specific plan to maintain the urine output?
IVC guided fluid resuscitation we can.
Okay. So IVC is 1.5 centimeters. Patient breathing spontaneously 1.5 centimeters with 20% collapsibility. What does it mean to you?
So collapsing, if it is more than 50% fluid responsive, sir. If it is less than 50, we have to be careful while giving fluids. So he may go into fluid overload. So we can start inotropic support. If he is not in.
No, 1 minute. I have given you the ultrasound findings. You know what the blood pressure is. Vital stable, it is written. Urine output is 30 to 40 ml. So what is that? What else you want to do for the urine output, or you don't want to do for the urine output? In other words, will you only monitor? Will you want to add on anything or not add on anything?
With the fluids, we can add a diuretic.
Albumin we can add.
How do you manage HRS, man?
Albumin.
How much albumin?
Albumin 0.5 to.
Okay. How can you say it is HRS?
Exactly.
Is it HRS in an acute liver failure?
Mostly we can.
HRS we can, pre-renal and HRS will be same, sir, as with urinary parameters. Both of them will have low urinary sodium and high urine osmolarity, and
Can you call it HRS?
No, sir.
Why?
So mostly, which is oliguria, and mostly we can we don't know the fluid status. Drug.
hemodynamically stable, sir. This patient mostly. So HRS.
HRS, when do you see HRS? Is it an acute liver failure or chronic liver failure?
What is the definition?
Chronic liver disease.
Then
We don't know if this patient has a chronic liver disease or not because we have not seen the ultrasound yet. He is an alcoholic known. Okay. So we cannot at this point, yes, we cannot say it is HRS. If let's say the ultrasound shows a shrunken liver, maybe you can say it is a part of parcel of HRS. So you cannot rule out at this point, but at the same time, you cannot even say it because you have to rule out other causes also. The first thing is baseline CLD you have to rule in. Then you have to rule out other causes of renal failure. What could be hypovolemia, it could be stones also. Patient may also have nephrolithiasis, right? Then it is completely different. So the first thing is first. Right. So what next? Next slide. So you got all the battery that you sent. I don't think anybody would spend all these batteries, right? So okay, you sent off all this battery and you got hepatitis E positive. Right, ultrasound is done. Hepatomegaly is there, some sludge is there, no ascites. Echo looks normal. What next? So you got hepatitis E. What else would you want to give? Somebody wanted to give N-acetylcysteine. What is the dose that you want to give? Why do you want to give N-acetylcysteine?
In drug induced. So he has a history of fever and he has taken paracetamol dose, unknown dose he has taken. So we can give N-acetylcysteine as there is a possibility of drug induced liver injury other than viral etiology.
Okay. If you want to give, how much will you give? What dose will you give? Instructions.
In acute liver failure, we'll give the 20% NAC. We'll give, sir, like 150 mg per kg, 150 mg per kg in 5% dextrose over 1 hour, and next followed by 100 mg per kg in 500 ml over 4 hours, and the next dose is 100 mg per kg in next 16 hours in 1000 ml. If we're taking orally, we can give the loading dose of 140 mg per kg, and subsequently 70 mg per kg we can give every 4th hourly till 16 doses.
Which is better?
IV is better. Oral tolerance.
Okay, what else will you do?
So we have to monitor LFTs, whether they are in decreasing trend or not.
What is the single most LFT which is more important to tell you that the patient is worsening?
Ammonia, we can. Ammonia.
INR.
Albumin, sir. Albumin.
INR. INR is the single most step because it has got a very short half-life. The PT prothrombin time will be the one that is right.
that is also the reason we would not want to correct the INR unless there is a clinical reason to do that. Okay, procedure or something planned. Because many times you'll see the hepatologist or the transplant team would require the INR as the most important marker. So twice a day we keep monitoring to ensure that if there is any worsening improvement, that is the only thing which gives us a good indication of the background liver function on a day-to-day basis.
Okay, next slide.
Fraction, oxy, and antacids. And
Yeah, I think we discussed this, Dr. Pavan. Shall we move
Yes,
to the
yes, next.
Yeah.
day 2, patient became lethargic and confused. So had severe abdominal pain and started on fentanyl infusion. And, so INR TLC became a little bit increased from 5,000 to 6,000, and INR 2.4, and creatinine same, almost the same, and bilirubin was increased from 39 to 42.
So what does it mean? This whole slide, what does it mean to you clinically
Patient is worsening
in terms of
INR and
liver function? So worsening liver function. What else?
And progressing to hepatic.
Encephalopathy.
hepatic.
hepatic.
Now you had the treatment chart, isn't it? Ceftriaxone, doxy, pantoprazole, etc. But you also have the etiological markers which have shown something. Do you want to make any modification on the treatment chart based on that?
Antivirals, you can.
Doxy, in case of liver enzymes, doxy we
Does he need doxy now? Based on what labs that you have already been shown, what is the final
liver enzymes.
What is the okay, fine, doxy will stop, but do you want an alternative for that, or you would not want anything? What is the diagnosis now?
Vitamin K we can stop, sir.
Okay, agreed. What is the final diagnosis now?
Now acute liver failure, which is caused by hepatitis C, viral pathology.
E, no? Yeah.
Which diagnosis also?
Hepatitis C induced acute liver failure with hepatic encephalopathy, with AKI, with coagulopathy.
What is the mortality of hepatitis E acute liver failure or acute viral hepatitis with E and A?
0.3 to 1%.
1%. When is it more high patients or whom? Who are the high-risk patients for hepatitis E viral hepatitis?
Eating outside, like who are traveling to endemic areas.
No.
Mortality.
Patients where mortality is higher, more severe presentation, in what category of patients or people? Who are high risk?
Pregnant patients. Pregnant patients.
Pregnant ladies. Okay.
Somebody is asking why should vitamin K be stopped? Can anybody tell me?
So mostly acute liver failure patients, they are not hypocoagulable. Sometimes their hypercoagulability status, hypocoagulability status. So there is no need to like most of the patients are hypercoagulability status, like more than 45 to 50% they are hypercoagulability. So then mostly we'll chance of bleeding, spontaneous bleeding are very less. So we can stop it, stop the vitamin K.
And what is the dose of vitamin K in a deficiency also?
10 mg.
10 mg.
Once a day.
Single dose.
Single dose for 3 days.
Okay.
Right.
Now, this patient has got admitted to the ICU. We'll just take one day backwards. What are all the things that you will be monitoring for this patient? Or what will you instruct your registrar that overnight, these are the things I want you to monitor? What are those things? It somehow maybe a bit of a repetition, but just to to be a little more clearer. Acute liver failure patient has come to you with whatever stable vitals and other things that we mentioned on day one. What are all the monitoring parameters that you would give to your junior doctor?
So for first is sensorium, sir. Any worsening of sensorium?
Yeah, just list it. Just list it. Sensorium.
Sensorium and any increase in abdominal pain, any BP, any hemodynamics we have to monitor.
Okay.
BP, heart rate, any changes. Any
Hemodynamics. Just list it. Don't waste much time. Huh? We have already gone through it in bits and pieces. What else?
Coming to CNS, we'll monitor the GCS and pupils. Coming to the CVS, we'll heart rate and BP. Respiration will monitor the saturation levels from the liver also. Liver and kidney will monitor the urine output, and we'll check the sugar levels every 6th hourly. We'll check the GRBS. And
monitoring of encephalopathy, what are all the other measures you could do? Sensorium, what else? Bedside, what else you would want to, if you have a facility to do everything?
Non-invasive measure to cerebral edema.
Non-invasive only, you're not intubated the patient, no?
Yes, cerebral edema, we can.
How will you monitor cerebral edema?
So by clinically.
Sensorium, okay. What else?
Pupil, sir.
ICP monitoring devices, but not regularly used.
Conscious patient, what ICP monitoring will do then?
You will put an ICP monitor. A lot of people are asking ICP monitor. Would you want to do an ICP monitor on a patient with INR 2.4 and a liver dysfunction?
No. Not intubated yet.
No, sir.
So how will you monitor?
So worsening of sensorium.
Yeah. So sensorium would be the main thing in somebody who is not intubated.
Sensorium, pupils, NST.
Those are the main things. So close neuro monitoring. Okay. Of course, you can use the ultrasound, but it's probably not very effective or not very easy to do in somebody who is conscious. You can probably use the onus or optic nerve sheath only after intubation. Somebody has written fundoscopy, that's too much. Fundoscopy is too late of presentation. Okay. What are the indications for intubating this patient?
Grade 3 or grade 4 encephalopathy patients, sir. We can and hemodynamic instability and respiratory failure.
Anything else? Dropping GCS, yes. Hemodynamics, agreed, all that agreed. Shock, then what?
We are giving fluids, sir, any volume overload.
Yeah, part of respiratory only.
Respiratory.
One important thing where we would have a low threshold to intubate this patient. In fact, people have already put it in the group also, one or two of them. Worsening acidosis. Okay, right.
Okay, next slide.
Patient sensorium progressed to grade 3, started on anti-edema measures. So 3% NSAL started and patient was intubated and kept on mechanical ventilator. So in view of metabolic parameters and duration of illness more than 7 days, transplant team opinion was obtained and workup was initiated. So INR further worsened to 4.8 and TLC further increased, and creatinine from 2.5 on presentation increased to 3.5, and the total bilirubin also from 39 increased to 44, and SUT, SGPT were also raised, and ammonia levels were also increased compared to day of presentation.
Okay.
And lactates were also
So,
increasing.
what are the indications for your transplant in this patient? When will you say, let's go for transplant on this?
One is grade 3, grade 4 encephalopathy. Grade 3 encephalopathy, sir. One is INR, sir. It is here 4.8 INR is there. So that is the one indication, and grade 3 encephalopathy also, like a.
No, what is INR supposed to be? How much INR?
It target less than 1.5, but more than 1.5, it is indication for.
No. You have to be, just don't be shooting in the air. How do you decide on a transplant?
Okay.
Yes, sir. According to King's College criteria.
So there is some criteria, isn't it?
Yes, sir.
Yeah.
Prothrombin time is more than 100 seconds, and grade 3 or grade 4 encephalopathy, and age less than 10 years or more than 40 years, and bilirubin is more than 18, and onset of illness to this encephalopathy more than 7 days, and prothrombin time is more than 50 seconds in non-estimate of induced renal failure, and etiology also non-A hepatitis B virus.
Yeah.
So there are two types. Okay.
Yes.
One is in
One
direct
estimate.
criteria. Yeah.
Yes.
One is based on pH, INR, and encephalopathy. Okay. Any pH less than 7.3 with INR more than 3 in 3 figures. That is PT more than 3 in 3 figures, and grade 3 and more encephalopathy, you directly wheel him into the transplant. If not so, then the other criteria will come into picture. Okay. pH is very important. Right. So what next will you do? Now your things are not working. You are giving 3% NS, infusion, boluses, whatever. Patient is continuously worsening. INR is worsening. Metabolic acidosis is also worsening. Bicarb is calling down. Lactate is still 4.4. Creat is worsening. What will you do next?
So if you not put it, you have to monitor. If it is decreasing, you can initiate dialysis. If urine output is worsening, so in view of raised creatinine and low urine output, we can initiate dialysis. And this HE measures like rifampicin and branchitine amino acids, they don't have any roles in acute liver failure. They
You tell me what is the role. You just tell me what you want to do. Okay. Tell me what you want to do. You want to do CRRT on him, or you want to do plate? Okay, let's say you are planning for dialysis, urine output drops. You got acidosis, which is worsening now. You got lactate going up. So what will you do? You can't take out lactate unless the liver is improved with whatever dialysis you want to do. Okay, but creatinine is going up, azotemia is worsening up, patient's encephalopathy worsens. If the uremia worsens, patient may have even seizure. Okay, then that will completely crash the whole thing. How do you know whether the patient is having seizure? The patient is intubated now, maybe even paralyzed and sedated.
EEG
what
monitoring.
Drugs would you EEG monitoring? What will you see in EEG?
With background activity, they will have spikes and waves.
If there are seizures, if there are no seizures,
Sometimes there is a raised ICP, we can have isoelectric EEG also will think about.
Isoelectric is
In encephalopathy, triphasic will be in hepatic encephalopathy.
so. What is the sedation that you would give in this patient? What is the drugs that you would use?
Short acting opiates, we can short acting opiates like benzodiazepine.
Benzodiazepine?
Yes, sir.
Opiates or benzodiazepine? What do you want?
Opiates, sir.
Anything else?
And profile also we can use, sir. It will decrease the cerebral perfusion pressure and cerebral metabolic rate. So
fentanyl also we try to avoid. No, short acting opiates also context sensitivity half-life will tend to accumulate.
Yes.
So which opioid is preferable in the ideal world? Maybe not so easily available in India, but
Remifentanil.
Remi and propofol. Okay. What is any other therapy you would? So before that, you said you will use dialysis CRRT, isn't it? What modality of CRRT will you use and why? It is preferable, at least theoretical indication.
Venovenous.
Venovenous only, man. Nobody does arteriovenous now.
Okay, give a prescription.
Give a prescription for CRRT. The nephrologist is not in town. So what will you do? Worsening renal function, worsening acidosis, worsening ammonia levels, increasing cerebral edema. Patient got intubated. Transplant workup is going on. In the meantime, you as an ICU person need to hold steady, maintain the patient. What will you do?
So dialysate flow, ultrafiltration, and blood flow, and ambient duration. We have to
Prescription for CRRT.
HD. So CRRT is a broad term, no? So which one will you do?
What is the difference? Just don't think that it is an acute liver failure. We'll only get questions on acute liver failure.
So hemodialysis, if there is volume overload, it is much useful, sir. It is short duration.
Doctor, what here? This particular slide is come to you now. This is how the patient is. Third day, sensorium is dropped. You have intubated. Have you intubated? Not yet.
Yes,
intubated. Yeah. You have intubated the patient. You have started on anti-edema measures. Okay, 3% saline you have chosen. You are doing optic nerve sheath. You are not able to do ICP. You are doing optic nerve sheath. You have done a CT showing mild cerebral edema. Ammonia is given here. This picture, what will you do? You have to start dialysis, yes or no?
Yes, sir.
Okay, what will you start? HD, SLED, CRRT. Okay, you said CRRT. What type of CRRT? Do you know there are types in CRRT? No?
Yes, sir. Yes, sir.
Tell me.
Scarf continuous venovenous hemofiltration.
Don't bring scarf.
Hemodiafiltration will do.
Hemodiafiltration. What is the difference between
SLED-F or CVVHF you are saying? HDF.
CVV-HDF.
Okay. So which one is used bit better off here? Okay, or you tell me the dose of HD and HF component.
prescription for your CRRT here in this patient? That is a classical thing. You will get a theory question also like this if you're in a DNB student.
Will you do online CRRT? Newer machines have online, or will you do offline CRRT?
What is the anticoagulant of choice?
We can you have to use citrates, sir. Patient is already on anticoagulopathy. You have to use citrate.
Will it be
citrate.
metabolized by the liver?
Yes, sir. But
Will it be metabolized here by the liver?
no, sir.
Then how are you going to give citrate? Where will you give citrate? If you give citrate, how will you give citrate? If you give heparin, how will you give heparin? So what is the replacement fluid? What is the dialysate flow? Will there be a dialysate flow in this?
Yes.
Sure.
Sure, sir.
Okay. So what will be the dialysate flow? What is the
Technician will
blood
ask,
flow?
yeah, exactly. How much dialysate, doctor? How much
Blood flow?
replacement and blood flow?
What is the replacement fluid? Where should I give the replacement also? Pre-filter, post-filter, what coagulation, what should I use? Citrate, heparin, where should I give heparin? Where should I give citrate? If I'm giving replacement fluid, where should I give the replacement fluid?
Blood flow will be low, sir, 50 to 100 ml per minute. And
Why you want to keep it low? 50 ml? BP is okay, no?
To maintain the cerebral perfusion pressure.
Well, normally,
How do
how
you calculate cerebral perfusion pressure?
Mean arterial pressure minus ICP.
When you don't have an ICP, how will you know?
Intubated patients, we can approximately ONSD we can measure.
NSD, you can get. Do you get the what do you call it? Pressure accurately? Yeah, exactly. Some it's 4.2. What does it mean to you? How much is the pressure ICP?
More than 5.5, we can think there is raised ICP, sir, ONST diameter. Less than 5.5.
No, doctor. What is the conventional blood flow that we start in CRRT, usual? 300
to 500 ml.
CRRT, you start 300? Somebody has written 20 to 30. Blood flow, how much? You have to beg and plead the technician if you have to go below 75, man. It's not that easy. You can go up to 50, it's okay, but it's very difficult. What is the conventional blood flow we start, CRRT? I'm again using my word CRRT, continuous renal replacement. What is the blood flow that we start with?
50 to 100. 50 to 100.
100 to 150 you can start, or even a bit lower if it is not tolerated. So what is the reason for you to start low? Okay, fine. What modality we want to know?
Continuous veno-venous hemodiafiltration.
What? Okay, tell me the dose of hemodiah and hemofiltration part. You have to set no on the machine. And as Dr. Pavan asked you, pre, post, how do you write a full prescription of CRRT? You can't just write 2-3 lines and go away.
If you are working in a closed ICU, you should be doing all this yourself. No nephrologist will come into your closed ICU. You're all looking forward for closed ICUs, and if you're not in a position to do this,
You are giving a scope to the nephrologist to tell that I will not close this ICU.
So, blood flow, dialysate flow, replacement fluid, and how much duration we have to order. So here dialysate flow will be high and blood flow will be low. So, CRRT. replacement fluid, we can use bicarbonate solution as acidosis is there.
No, replacement fluid comes as so you don't have to do anything for it. No, you want to add more bicarb. Are you saying that?
So, as acidosis is
So what is useful for clearing the ammonia? Ammonia goes through convection or through diffusion?
convection.
Convection. Which one is convection? HD or HF?
So HD is diffusion, sir. HF is a convection.
So which one is the choice here? Or which would be the larger component, theoretically at least?
HF, sir.
HF is more important, no?
More important.
Then, in fact, you may have to keep a slightly higher hemofiltration than normal if ammonia correction requires slightly higher. That's anyway debatable.
So somebody is asking, can we do plasmapheresis for him? You can't get an organ. What else are there for other things that you want to do?
So plasmapheresis, mostly evidence is there for only Wilson's disease, sir. Better outcomes. Other causes of acute liver failure, there is less evidence that it shows mortality benefit. Only in Wilson's disease we can.
Toxins? Toxic hepatitis? There's no evidence.
Toxic. If you do early before deterioration, there is some benefits. If you initiate early plasmapheresis.
What is MARS?
Plasmapheresis is now a level 1 evidence, man. Level 1C or something like that. It's actually, it has shown to actually increase transplant-free days and survival. Okay. So high volume plasmapheresis is actually recommended as a bridge therapy till such time that you are able to get an organ or the patient improves.
What is MARS? And what do you mean by MARS? What do you do in MARS?
MARS is a molecular observant recirculation system, sir. Here the blood flow will against the albumin, we are using albumin as a dialysate fluid. So the albumin bound compounds were removed by the MARS. They will have two circuits and in that albumin circuit will be there. So there the blood flow will against the albumin dialysate. So the albumin bond things they will removed by this MARS.
Okay, next slide. So you're up a drop, you did a dialysis. So this is what
we have discussed, I think, now, Dr. Pavan.
Next slide.
So blood and urine cultures were previously, which were sterile now, and the patient still was febrile and TLC counts were still rising, and so repeat blood cultures were sent and antibiotics were escalated. So to carbapenems and teicoplanin. So to cover gram-negative bacteria, most common cause of sepsis. And antifungals.
Next slide.
Patient shock worsened and dual vasopressor support was initiated and CRRT was initiated. And patient condition deteriorated and the patient was died after 24 hours due to septic shock and acute liver failure.
Okay. So I think I don't know what was the time limit. We have actually probably crossed it.
Yes,
Dr.
yes. Yeah, that's what I think. We should just focusing, trying to see. Nobody will ask you questions or not blame you if you don't know about plasmapheresis or mass, or even the lung, or maybe even criteria for liver transplant is important. But at the same time, if you're missing out one or two there steps, nobody will bother. But initial thing, differential diagnosis, especially at your level, for the IDCCM and CTCCM students, it is a differential diagnosis. And are you safe enough without doing much harm? If you don't miss the basics, right? How you are going to manage the patient immediately, getting that proper diagnosis, looking to the differential diagnosis, your thinking process should be right. How you approach the patient, that is important. So you may not, people will not mark you mere on marks and other things, but the basic things should be important. See, whenever you are seeing these cases or whatever in the exam, think about what you will do naturally in day-to-day practice. Yes, you are always surrounded by consultants who give the instructions and you are just following them. But think what you will do as a consultant, as an individual independent consultant, what would you do? So just telling general statements like I will start this anti-edema measure, I will just to monitor sensorium is not enough. You have to be specific. If you are not evaluating, or if you think that you want to do something, but you want to do this, I don't want to do this, you need to specifically look into those things and then specifically say why you don't want to do this. See, nobody will ask you questions, why this medicine only, why that medicine only. If you can substantiate it, that's well and good. So look at those important points are in the first initial 3 slides only. The last 3 slides are anybody will tell theoretical. Okay, don't go telling I'll put ICP monitor, which you don't do in your ICU. If you're doing in the ICU, it's a different thing. If you don't do in your ICU, then don't do those blunders and say I'll put an ICP monitor and measure CPP. Okay, so don't do what you don't do. You can easily say that I don't do ICP monitor routinely, so I won't do here also in this situation. And again, so be practical what you are doing. Nobody is asking you to.
Just for your information, actually ICP monitoring is now less and less used as a modality for monitoring, because we have owners and a lot of other things where we are likely to monitor, and we can monitor actually non-invasively. Because again, when you do an ICP for this, you'll have to do a subdural bolt, which is also itself not very accurate like the normal intraparenchymal devices or the EVDs. So don't unnecessarily put yourself into like a foot in mouth kind of problem. Okay. Sorry, Dr. Pavan, go on.
Yeah, that's fine. That's what I'm saying. Generally, it's not just that in this concern with what ICP, but you should do what you are doing in your ICU. You do CRRT in your ICU regularly. So you should know what is the dose, how it is prescribed, and what they're doing. So the same thing, what you do in your ICU is important. That is what you're doing day in, day out. Don't go for high funder things. Don't need high funder things. What you're doing routinely, that are important. Just understand what you're doing day in, day out, why you're doing each step. That is what you should you should go back, and when you're doing it in your bedside, you should say why I'm doing this, why I'm doing this step. What is this step useful for? What is this step? Why we are not doing this? So there should always be having that kind of discussion with your consultants when you are there. So don't think just always try to see. Nobody after some point your consultants will not ask you the questions. You should ask the consultants your questions so that you extract all the information from there. Okay, that is what you should do in your daily rounds. So just don't follow bad things. Okay, you should go back, read, and apply that in bedside. When you have a case like this in ALF in your bedside, you read about ALF. At that point of time, you will recollect a lot of information. You will have a long-term memory about it, rather than just reading about ALF when the case is not there in front of you. So when you see a patient, read it about it, then only you will remember more about it, what needs to be done, what not needs to be done. Okay, that's it from me. Dr. Sunil, your final comment.
That's about pretty much it, yeah. Good show.
Yeah.
Thank you, Anand. Thank you, Kondal.
Thank you, sir.
Yeah.
Thank you.
Sir, can you hear me?
Yes, Venkat. Go on.
Yes, please, Dr. Venkat.
Yeah, I think it was 1.5
You have
years.
heard all
of,
over the country, Dr. Venkat.
Yeah, so thank you, both of you, Dr. Pavan and Dr. Sunil Karanth, for your valuable time and probably sharing all your academic experience, not just on the part of exam preparation, but probably as a clinical management on the bedside, giving the all 360-degree angles from the differentials to this point. I think that's what we are looking at from this case presentation. It is not just about an exam preparation alone, but how clinically you do at the bedside, how you should actually keep an eye on all the possible differentials to end of the treatment till the transplant or a bridging therapy. I thank Dr. Anand and Dr. Kondal in bringing this case. So we do understand there will be a lot of innovations and all that during this when you prepare and appear an exam. But it has to be, I think, a day in and day out practice for you in your round, so that you will be more habituated to this kind of interactions when exams come to on board. So I thank all the participants. I think there will be always, I see a dynamic participation. Every time you ask a question, you see 10, 15 answers pouring from here and there. And you always see 300-400 comments, charts coming up. And generally over a time, in a day or two, we see around 1,000-2,000 viewers for this master classes. So I hope we will bring more similar sessions. I thank ICM Hyderabad chapter, who has been a significant contributor in supporting this program. I also thank Yashoda Hospitals and the digital team and the management who has been supporting for this program. And I thank both of you, Dr. Pavan and Dr. Sunil, for your excellent moderation and clinical reports. I conclude the session. Thank you all.
Thank you.
Thank you, Dr. Shashi. Thank you, Dr. Venkat. Thank you, Dr. Sunil.
Thank you, Dr. Karan. Thank you, Venkat.